So I think the reason that this is such a well-attended talk and such an important issue is because there is growing acceptance of the fact that healthcare in the United States costs too much and our health outcomes are insufficient for what we want. And to be very specific, I was recently at a lecture where someone got up and said, if the US had the per capita healthcare costs of the second highest country in the world, how much would we save every year? And he put up 10 billion, 100 billion, or a trillion, and the answer is $1 trillion every year. If we just had the cost of the second highest country in the world, which is Norway. And then in terms of health outcomes, there was a great study that was just put out by the National Academy of Medicine, part of the National Academy of Science, which showed that the life expectancy of both males and females between has slipped from middle of the pack among industrialized countries to the rock bottom of all industrialized countries in the United States. And particularly among women, there's a decline in life expectancy at the lower socioeconomic, bottom 40% of income, and only the top 20% has seen an increase from the cohort that was born in 1930 to 1960. So we are totally losing ground in terms of life expectancy compared to our other countries, and we're spending $1 trillion more than we would if we had the second expenditure. So that's why I say there's a growing acceptance that it costs too much and we're getting not enough health for the investment. Every state experiences that differently. And I was the health secretary in Maryland for the last 4 years, ending in January. Every state experiences it differently. Every state can have its own solutions. But there's a common principle that's emerging on how you get better health at lower cost. And that principle is you pay differently for health care. You don't just pay for stuff, for procedures, for hospitalizations, every single one, again and again, that you align your financial incentives so that money goes as health improves. And states have very different ways of going about that. I'm very impressed with what Tennessee is doing. Tennessee and Maryland are typically maybe not on the same, color scheme when it comes to politics. But believe it or not, underneath all the politics of the Affordable Care Act, there is a huge consensus in this point and a lot of innovation going on that you get better health at lower costs if you pay differently. So let me tell you about the Maryland flavor of that discussion. When I was health secretary, and each state starts at a different point and has different tools available to it. In Maryland, we have the only rate-setting system for hospitals. It's been around since the late 1970s. And what that means is that every hospital in Maryland gets basically a rate card set by an independent commission, and all payers pay off that rate card. That's Blue Cross, that's Kaiser, that's Medicaid, that's Medicare. So Medicare pays Medicare rates in 49 states in the District of Columbia and pays Maryland rates in Maryland. And that's been going on since the late 1970s. There were a few other systems like that. They all dropped off. Only Maryland has it. There were some good things of that system. Just as an example, there are no public hospitals in Maryland because all of the uncompensated care costs were pooled between the hospitals. There was an assessment placed on every single hospital bill, so it was fair, about 6 or 7%. All that money goes into a pool. It goes back out to where the uncompensated care was. So every hospital can see the uninsured in Maryland. So traditional system. Then I became secretary, and the system almost imploded. Those events weren't totally cause and effect, but it was my good fortune to be starting right at that moment. And what happened was there were some strains in the system. Medicare only participated in Maryland's system if certain conditions were met. And one of those conditions is that we could keep the price of a hospital visit, the way that those prices grew, lower than the rate of price growth nationally in Medicare. Basically, Medicare made a deal with Maryland that said, we know we're going to pay higher prices for hospital services in Maryland, but as long as you grow more slowly than the rest of the country, we're okay with that. There were a couple problems. One was we couldn't keep the prices down. It was causing a lot of problems in the hospitals. And one of the ways they were coping with that, as their profit margins or their nonprofit margins were getting squeezed, is that they were doing a lot of volume. And I used to say when I was secretary, if you can only make $2 on a pair of pants, you have to sell a lot of pants. Well, in Maryland, you could only make a little bit on each hospital admission, so we had some of the highest volumes in the country. The second problem is, even with that, we couldn't keep the prices down, and the federal government was going to back out. The whole system was going to collapse. This was only in Maryland, so this is what we inherited. But we saw it as an opportunity to do the basic thing of aligning our financial incentives with better health and rethinking the system. And the key to what we did was, in rural areas, we've been doing a pilot in Maryland with 10 hospitals for 3 years. And the pilot was, we gave every hospital a global budget. That meant in advance of the year, the hospital knew their revenue. No matter how many ER visits, no matter how many admissions, how many MRIs, they knew their revenue. If they could prevent admissions, they would get to keep the difference. And I could go into more detail if you're interested in how you do that, but basically the way it works is, if Darren is the rate-setting system and I'm the hospital, and he goes, okay, Josh, we've agreed on a $100 budget for next year. How many admissions do you think you're going to have? And I go, I think 10. He goes, okay, I'll let you charge $10 for each admission. But if your admission rate starts to go up, so it looks like you would get more, we're going to start lowering the price that you can charge. And in the end, you're going to have $100. And if it's lower, that admission rate, and it looks like you're going to get less, we're going to allow you to charge more for each one, and you're still going to wind up with $100. So as our system was starting to come apart, I visited this hospital in rural Cumberland, Maryland, called Western Maryland Regional Medical Center. And I went into this beautiful new hospital, and I went right back out because I thought I'd gone into the wrong door. It was so quiet. And this guy comes bopping up to me. He's the CEO. He's so happy. The hospital's like 60% full. It's like any other CEO. They're a huge new hospital, 60% full. They're like on monster.com at their desk looking for another job. He's got a global budget. He takes me to the emergency department. They've got a team that meets with every single patient to figure out what their plan is, who their doctor is, can we get you an appointment, can we get you medicine, so they don't have to come back to the hospital. They send out nurses twice whenever someone's discharged to a nursing home to make sure that it's a good transition of care, the patient doesn't bounce back and have a problem. He started a campaign of staff education at the hospital, which he told me the theme was basically, we hope to never see you again, for the patients. So you go to a lot of parts of the country and the hospital's like, only 2-minute wait in our emergency department, come on in, In Maryland, it was like, what can we do to keep you healthy? Because they get to keep the difference. He took me to wards that he closed because they didn't have the need for them anymore. And he showed me clinics that they open for anyone with asthma, heart failure, diabetes, pharmacists, nutritionists, helping them stay healthy. Huge reductions in preventable admissions, huge improvements of health in that county. They have a hospital has a bridge to the health department. They said they've never used that bridge more because now what the health department does actually helps the hospital's bottom line. So we went to CMS, we showed them the results from these pilots, and we said we want to do that for the whole state. And starting January 1st, 2014, Maryland became the only state to end fee-for-service payment, basically, for hospitals. All payer. This is not a Medicaid initiative. Every time I give one of these talks, I get an email, tell me more about what you did in Medicaid. This is not just Medicaid. This is Medicaid. This is Medicare. This is Kaiser. This is Blue Cross. This is United. Everyone's in. Why does it matter that everyone's in? Because if you're you're using your Medicaid and you only have, maybe that's 20% of your hospital volume, and you're doing something creative about financing for 20%, but 80% of it is still the traditional way, it's hard to change your system. You can't do a we hope to never see you again, complete transformation. But if you can work collaboratively together with all the payers, then to the healthcare system, it's like, now we've got a chance to do something really fundamentally different, and that's what we did. We set the goal over 5 years of getting 80% of the revenue off of fee-for-service by these different creative mechanisms onto global budgets for every hospital in Maryland. And within 6 months, they moved 98% of the revenue off of fee-for-service. So in Maryland, every hospital has a global budget, and they have a financial mission to reduce preventable admissions. Their finances are aligned with better health. Maryland achieved the greatest improvement of any state in America's health rankings as this was evolving. We have projects on mental health, drug addiction, community outreach, of different kinds all across the state. I was just at a hospital where I'm a pediatrician. The pediatrician said to me, we've been asking for years to get home visitors to help with our kids with asthma. And now the hospital's paying for them. I don't know why. I said, I think I know why. Another hospital took over the school health program, and I called the CEO. We've never had any hospital take over the school health program. We took it over because we realized we're losing money every time a child comes to the hospital with asthma. But if we can run the school health program at break even, really focus on the asthma, we're gonna make out like bandits on the back end. He didn't say it exactly that way. But just think about it. Every hospital in the country, generally, most hospitals, they make money when kids can't breathe and they have to go to the emergency department. It is against their financial interests to keep kids healthier because they would lose money when they come in. That's not a moral judgment, that's just a fact. It's the wrong way to pay for health care. In Maryland, we've changed that so that the hospital gets paid more if there are fewer, gets a better margin if there are fewer kids having asthma. That's what it means to align the incentives. There are other ways to do it besides the Maryland model, but that's how these were the tools that we had. So we published recently in the New England Journal of Medicine the first year results in Maryland. We beat the Medicare cost trend by $116 million, a 25% reduction in preventable errors, because now all those errors are coming completely out of the bottom line, and hospitals are incredibly incentivized to reduce them. The hospitals are putting money into regional public health partnerships around such issues as preventing falls, improving access to care for adults with chronic illness. They're using electronic data in all sorts of ways. They're partnering with the health department, and it's a really exciting moment, I think, to see health and public health come together around an innovative financing approach. I will just say that a lot of people, when they think about health and public health coming together, think about community benefits. And I care a lot about community benefits. When I was the Secretary of Health, I talked to hospitals until I was blue in the face about community benefits. One of them had a community benefit of sending ultrasonographers out to churches and doing scans to see who needed a carotid endarterectomy, asymptomatic carotid endarterectomy, which is not recommended by anyone, okay? I called it was the No Vascular Surgeon Left Behind program that the hospital had. So, eventually they stopped that. What we're talking about when we align the incentives for health is that it's not just the Community Benefits Office. The Community Benefits Office is now working with the hospital. The hospital's mission becomes to improving the health of the community, and it's very, very exciting. I gave myself 15 minutes and then questions, so I'm going to tell one last story. When I was the City Health Commissioner of Baltimore, one of the great things about working at the city level is like the whole government is with you, at different events. You're with the police chief, the fire chief. So I'm in the emergency operations shelter. I'm in line for bagels with the police chief and the fire chief. And the fire chief says to me, here's the problem we have. We're having trouble with our ambulance response time. We have certain people who keep calling the ambulances, and it's hurting our ability to respond to real other emergencies. Can you help me? And I said, sure, we'll send out nurses and case managers. Can you give me the list of the top 10 people? So he gave me the list. First one was a 93-year-old woman who was absolutely healthy. She was lonely. She thought the ambulance guys were cute. She called them every single day. They went out there. We found her a sufficiently cute replacement home visitor. Never called again. Second one was a guy who thought when you give insulin to someone, the person should be going unconscious. He just thought, and he gave the insulin twice a week to his wife. She went unconscious, went to the ER, and we got the right dose of insulin. If they're medical historians here, the treatment for depression used to be to give people insulin until they seized and then give them glucose until they woke up. This was before antidepressants. It was sort of like a poor person's ECT. So he might have been treating her depression unwittingly. We don't know, but they solved that. Never called again. We published a paper that this intervention was cost-saving for EMS transport alone. Forget about all the costs in the emergency department, all the costs on admission, cost savings. And we had this meeting in City Hall with all the ER directors where I presented the data, and they're like, hugging and kissing each other. Not really, but they were very excited, okay, and then we had a medical student with us. And I'll finish the story. That's my halfway through timer. And a medical student with us, she said, this is great. Now all the hospitals can put in money and we can expand the program. And it was an emperor has no clothes moment. All those hospitals were paid fee for service. If we expanded this program, it would be taking money away from their budgets. We were sort of felt guilty and awkward, and we wrote all the hospitals. None of them went in to expand, okay? Now those hospitals are on globe. That little program was nursed along by the city fire department, still exists 10 years later. And now it's growing with funds from the hospital because they have an experienced model, and the hospitals actually do better when those patients get the right care and don't need to come in. That's the healthcare system we need. There are different ways to get there. You got to look at your own state's unique skills, but there's too much money being spent for too little results, and changing the payment in the right way can make a huge difference. Thank you.